Welcome to the BrainX Community Live May session. Today we have a very special session. We're going to talk about the artificial intelligence in cardiology. But before I introduce the moderator of this session and go to the actual topics, I would like to, especially for those who are joining us for the first time, give a little bit of an overview of BrainX Community and who we are. So BrainX Community was conceived 3 years ago, and those 3 years have been very successful with the overarching goal of promoting machine learning education in healthcare, and also trying to connect people who have interest in AI in healthcare. We have thus far 3,000 and counting members who are spread internationally. We have 2 web pages, BrainX AI and BrainX Community. We are very active on LinkedIn group, and we have monthly BrainX Community live sessions. Also, over the past year, we branched to Europe. So we have BrainX Community in Europe, and a year ago we had very successful meeting in jointly with BrainX Community EU, and we're planning another meeting at the end of this year. And also BrainX Community website, it's a good source of information. We have, when you go to the website, 3 sections. One section is Connect, where you can find the listing of current BrainX Community events and also past BrainX live sessions. There is a BrainX Community Learn section where which contains the lists of curated articles, which are divided into specialties, and that gives a lot of information about ongoing and current research in the arena of artificial intelligence. And finally, we have the repository of the open sources data sets, which are available for the researchers and investigators to tap into when they try to develop new machine learning models. We are present on YouTube channel, and all BrainX Community live sessions, including this one, are posted on a YouTube. So if you subscribe, you can have access to all of those. And recently we launched a podcast. It was a brainchild of Dr. Alok Kothari and Ashish Khanna. And podcasts are available on Spotify, Apple, and Google platform. And essentially, those are discussion with the experts in healthcare, in AI, about the research, about the vision for the AI application in a healthcare, and about the future outlook of AI in a healthcare. Now, as I mentioned, we are very active on LinkedIn. We have over 1,800 members and still counting. It's a very dynamic group. There is a lot of exchange of information, exchange of current research and articles. So if you haven't joined, please do. So we are present on different platforms. So you can pick and choose whatever works for you. And finally, last but not least, at the beginning of each calendar year, we publish under the leadership of Dr. Mathur, Artificial Intelligence in Healthcare Year in Review. It is essentially assembly of all work or publications in healthcare, which are to some involve artificial intelligence or machine learning. And those are divided by specialty. And we have specialty contributors who not only handpick those articles, but also give the overview of what was significant, what was the most important achievement in respected subspecialty. So in cardiology, as you can see, last year, it was pretty productive year in terms of number of publications. And hence we have this session devoted to cardiology. So I think this is a good segue to introduce our moderator for today, Dr. Avirup Guha, who is assistant professor of medicine at the Case Western Reserve University School of Medicine. He's also a consultant cardiologist at Harrington Heart and Vascular Institute, and his clinical and research interests are deeply rooted in artificial intelligence and implementation of artificial intelligence in the clinical practice. So with that, I will pass the microphone to Dr. Guha, who will introduce our speakers and also give some opening remarks. Avi?
Can you guys see me?
Yes.
Okay, let me share my slides. So let's see. Can you see the screen slides?
Yes.
Okay. So thank you, Piyush, and thank you, Jacek, for inviting me to this exciting BrainX Community Live. I always like coming to these as audience, and today I'm glad to be presenting on advances in artificial intelligence and cardiovascular medicine. As Jacek pointed out, we had done quite a bit in the field of cardiology, and in this year in review, I had reviewed the cardiology section, which basically means going through all the manuscripts which came out in the field of AI and ML in cardiology over the whole year of 2020. And the number of manuscripts had doubled from the year before to 140 manuscripts. The most common cardiac modality, which was the source of data for all kinds of machine learning modalities, was EKG. There's been obviously increase in use of cardiac MRI and cardiac CT, as these provide high quality images for deep learning studies and computer vision studies. There are obviously newer sources, and this year I noted Holter monitoring was a new source which is being used for some of these studies. Given the increase in the number of manuscripts and data sources reporting on the same outcome, I did notice many more meta-analyses than the years before. So I was also tasked to pick 3 important studies in 2020. So one of them studies are going to be presented later by my colleague. I'll try to talk about 2 of them. So the first one was this study which was published in Circ Arrhythmia Electrophysiology. And I really liked this study because it used EKG and used deep learning to identify if the patient had left ventricular dysfunction. As you might imagine, the emergency room faces a lot of patients who come in with shortness of breath to the ER, and the standard evaluation takes much longer, and most of the patients don't get an echocardiogram up front. So this modality was actually as good as standard of care and gave a fair idea of LV dysfunction in this very well done study. The second study, which I really liked, was this deep learning study, which used echo images to identify wall motion abnormalities. One of the things we do in cardiology is when we read an ecocardiogram for somebody who's had a prior heart attack or is having a heart attack, is we look at their left ventricular wall motion, and that helps identify what part of the heart might be involved. And they used echo images and did convolutional neural network analysis to figure out that they were able to identify wall motion sometimes equal or better than a human reader. So this was very interesting to me, and obviously has a lot of importance because that is sometimes the first check of finding if the patient's having a heart attack. So with that, I will segue to the first speaker. The first speaker, I'm going to stop sharing my screen while I introduce the first speaker. So the first speaker is Dr. Vardhmaan Jain. He's a current internal medicine resident in Cleveland Clinic and has keen interest in healthcare innovation and cardiovascular medicine. Prior to joining internal medicine residency, Vijay completed his medical school at Maulana Azad Medical College, Delhi University, where he was a gold medalist in pharmacology, public health, internal medicine, pathology. He also serves as a research consultant for Recora Health, a healthcare venture aimed at expanding the reach of cardiac rehab and helping health systems optimize outpatient health failure management. In his free time, he enjoys playing and watching cricket, traveling, and hiking. So with that, I'm going to have Vijay share his screen. Please put your questions in the comments and I'll come back to those at the end of the presentation. Thank you.
Hey, thanks, Dr. Guha. Thanks for introducing me. Can all of you hear me?
Yes.
Yeah, let me just quickly share my screen. All right. So yeah, so basically my presentation is going to focus on how artificial intelligence can help cardiologists and what cardiology has to offer through the benefits of artificial intelligence. And it's going to focus on what we know so far and what we can expect going forward. Um, I was mentored through this project by my mentor, Dr. Ferris, who's with us as well. And he kind of runs the global patient outreach program, as well as the liver transplant program from a cardiology standpoint. Um, and I think he would also like to introduce himself and speak a few words. Dr. Ferris.
Thank you, Vijay, and thank you, everyone. I'm actually very happy to participate today and be introduced to this wonderful society, which I plan to become part of. I think what Vijay will, this is 100% Vardhmaan project, and I'm really very proud of the work that he has done. I work very closely with Jacek and the rest of the anesthesia team in liver transplant, and we struggle on a day-to-day basis in terms of looking at what indicators may predict patients that have cardiovascular disease and are about to go for liver transplant. We discuss often coming up with a scoring mechanism for those patients that will give some weight to certain risk factors that may be more important than others. And hence we become perhaps the accidental AI amateurs, and here comes Vijay and really kind of pulled something very impressive with some significant work over the last few months. To be honest, we've had to review this manuscript several times and look for noise in our own data to make sure that what we are presenting is clear and represents a good academic exercise. And Vijay will discuss this with you in the future. And last, I want to say something that as we learn more about artificial intelligence and AI, I think I've heard this from one of my colleagues that those who artificial intelligence will not replace us as physicians, but those who will not adopt artificial intelligence will probably be replaced in the future. So it's going to be part of our future. It's here to stay, and we need to adapt this technology and learn more about it. And I'm very thrilled to realize that there is such a community, and I'd be honored to be part of it. So with that, Vijay, please go ahead.
Thank you, Dr. Ferris. So just a brief, like Dr. Guha introduced me. So I'm from Delhi, and that's my med school. And I'm right now at Cleveland Clinic. I love cricket, and that's like one of the happiest days of my life. That's the day the Indian cricket team won the World Championship. And I love hiking, and I was recently in Yosemite National Park, and I took that photo, and I think that's kind of cool. I wanted to share it with all of you. But so moving forward, conflicts of interest, we kind of went over them. So just a brief up, like what do we know about AI and why do we even need to know about it as a cardiologist standpoint? So AI and machine learning are two words that are used kind of synonymously. But if you would really like to be granular, then artificial intelligence really just focuses on how the computer-generated algorithm can learn from data and give meaningful results. And machine learning is kind of the tool that artificial intelligence leverages to do that. But for all practical purposes, we can use them synonymously. So essentially, it helps us identify and quantify and interpret relationships with large volumes of data. And I think the advent of AI for healthcare professionals becomes more important with the advent of EHRs, because when we had paper records, there's no way somebody's going to collect like 1,000 papers and then try to, put them together in an Excel sheet and run an algorithm. But I think it becomes more important with electronic health records, where there are like thousands of variables for each patient, and there are thousands of patients in each department, and then on and on and on. So I think to improve the quality of care, I think AI can be our friend. And I think there's constant pressure on physicians and cardiologists to improve their efficiency, to improve the quality of care they deliver. And I think with more and more technologies that are coming up, like people are wearing Apple Watches, smartwatches, EKG reading techniques, new imaging modalities, I think the amount of data is just exploding. And I think just to give you an estimate, after 2004, all of the internet that existed has doubled before 2004 known to mankind. So we're really moving forward fast. And like Dr. Fair said, AI is our friend. It can never, for the foreseeable future, replace what we have to do as physicians. Specifically, the FDA has yet never approved something that is an independent AI model to perform a physician's task. The closest we've gotten is a retinal reading technique that uses to screen patients who have routine screening diabetic retinopathy examination to see if anything's wrong or not. And if it flags someone, then the physician does a manual fundoscopic examination. But that's the closest we've been. So it can really, really augment all stages of cardiovascular medicine in terms of research, discovery of new drugs, and then selecting those drugs and to see which patients would benefit the most from those drugs. So kind of like a full spectrum almost. And the benefit that AI has, as you might know, that it's not limited by traditional statistical assumptions. And what we mean by that is that traditional statistical assumptions want like a lot of rules to be obeyed, like data should not be homodiscretic, and they should in that sense, they only recognize identifiable patterns and data, and a dichotomous answer is usually what the machine throws out, the algorithm throws out. So you can either have the disease or not have the disease, and then gives the risk. But in reality, we don't see that. We see patients across the spectrum of disease, like what's the likelihood that he might have it? And then suppose if somebody has 80% risk, you might just treat it. But if somebody has 40% risk, you might not treat it. But traditional statistical techniques can't give us an answer on that spectrum. And I think that's where machine learning has its most powerful role, that it gives us a prediction of the risk, which traditional statistical techniques have failed to do. And I think in that sense, AI is pretty powerful and can take in large volumes of data and give us meaningful conclusions if done correctly. So this is just an estimate of what the world thinks of healthcare and AI. And I think I have a lot of friends who are not physicians, but are engineers and economists by trade. But in the last 5 years, my personal experience has been that their interest in healthcare startups and healthcare AI has just exploded. And this figure kind of sums up what we see in real life, like the amount of investment and funding that healthcare AI-based startups are getting is just phenomenal. And it just goes to see that it's not just physicians or engineers, but even people who don't have that background believe that this is important, and that's why they're putting the money in it. And just as a brief up, some of the big stakeholders right now are Microsoft, Amazon, Google, Facebook, Apple, and IBM. And off note, that retinal reading technology that we talked about, that was developed by Google, I think, in partner with one of the hospitals, and that got FDA approval recently. And right now, at our hospital, we see AI in scheduling tasks, in scheduling cath labs, scheduling ORs, scheduling outpatient appointments. So I think that's the biggest task it's helping. And also for predicting mortality and readmission. So in our hospital, when we try and discharge somebody, there's a readmission and risk score predictor, and that's kind of like a good reflection of the use of AI in healthcare. EHRs also use them to flag patients with conditions that can cause like high fatality, like sepsis. So whenever in Epic we get flagged that patient was flagged for sepsis, that's actually the AI looking at like 6 or 7 fixed parameters that trend, and then saying, okay, make sure you're not missing sepsis. And then suppose when Epic flags, or you should consider using ACEs or ARBs in a patient with heart failure, or beta blockers in a patient with recent reperfusion, I think that's another application of AI using EHR data to tell us how to improve patient care. And the big pharma companies, that's a big one. They're using AI to speed up the process of R&D. And I think given the interest that we saw this year with the COVID vaccine being developed in 1 year instead of the traditional like 40, 50 years to develop a good vaccine. I think that's kind of a reflection where that field is headed. And I think AI has a big role in that, in the sense that a large volume of raw data in terms of gene mapping, in terms of drugs and their receptors, how they interact and which interactions are important and which ones are not. I think going through, it can simulate a lot of those experiments for us instead of us going out and doing each one of them. I think that's why it can really speed up drug development. But like Dr. Guha said, in cardiology, I think the biggest explosion that's we're going to see in the years to come is in cardiac imaging. And that's going to be a different topic in today's conference. And then clinical trialists have been using AI recently to improve the recruitment of participants, because it's really tough to find like really good case controls in a randomized control trial. And large part of the funding is actually spent on recruiting participants. For example, if you show all of Cleveland's hospitals data to a well-trained algorithm that knows that I'm going to pick up all the patients who need fish oil for primary prevention, then it'll automatically scan the EHR to see diabetics with high ACV score, and he would say, hey, these are like good participants. So I think in that sense, AI has been really important in helping the recruitment of clinical trials. So that's kind of like a brief overview of what we can expect in terms of the applications of AI. And I really like this figure from Johnson et al. That was published in JAC a while ago. And it kind of summarizes what we talked about. So it can really help in diagnostics and therapy selection, which can really be powerful for clinical practice. And I think for research and development, it really helps speed up the discovery and development of new drugs. And helps in integrating genomic and multinomic data. And these all in turn help in providing precision medicine, something that we'll talk about during my presentation as well, which means that each patient's genetic makeup, risk factors will be taken into account to help cater healthcare specifically to that patient. And it will improve our efficiency and efficacy as physicians, because all of these mundane decisions, a lot of the EHR tasks that we do, like, oh, where is the billing tab, where is the plan, how do I add problem lists, all of those can be taken by the software, hopefully in the future, and then we can focus our energy on actually making medical decisions and not being an epic monkey. I think, like Dr. Guha said, it really helps in remote monitoring. And I think there's a really interesting healthcare startup that came out in a city in India called Bangalore that uses EKG and portable echo reading using artificial intelligence. And it has been really, really successful in screening patients who have STEMI and also telling them which is the closest hospital in areas which do not have access to healthcare or a physician or somebody who's trained enough to read an EKG. So that startup has been able to successfully really bring down mortality due to ST elevation MI in that radius in Bangalore, and that sort of made it to one of the global Forbes 30 and the 30 this year. And I think that's kind of like personifies what we mean about remote monitoring and diagnostics using AI. And it can also help in optimizing resource allocation. Like we kind of talked about the clinical trials and where to use money in research, drug and development. So like, yeah, I think most of you might be familiar with this, but for novel readers, I think it's a quick revision of what it entails. It can be supervised or unsupervised machine learning. Supervised machine learning focuses on problems that we commonly encounter in clinic. Basically, it's either a classification or a prediction problem. The classification problem, we want the algorithm to tell us, will this patient die or not die, or get readmitted or not readmitted, or will he be successful on this drug or not successful on this drug. So those are like kind of like classification problems. And then prediction problems are something like what we did, that what's the probability that he will have an adverse cardiac event in the next 6 months after his transplant, or what's the probability that if he gets this drug that his cancer will get cured or come under remission or just be not metastatic. So those are like the supervised machine learning tools. And then unsupervised machine learning tools are kind of more interesting, where the algorithm just goes, is just let loose on raw data, and it's asked to identify relationships between variables in a data set. I think a really interesting study that came out from the Brody Institute this week, Dr. Kera's lab, was that looked at how different kinds of visceral adiposity differs in different people. Their study looked at like imaging-based machine learning to classify the types of visceral fat, and they found really, really interesting signals that based on the patterns of distribution of fat, even lean people might be at high cardiac risk depending on where their fat was, compared to even sometimes obese people if their fat was not in that place. And that was only because of the use of an unsupervised algorithm on raw data. So the applications are pretty immense. And then this is kind of like an overview of how we go about building a machine learning model. We have our data sources, which could be just a lab experiment, clinical data points, smart wearable technology, and then we do something called feature engineering and feature selection, where we just clean the data set, make sure that all data points are adequately represented, think of our problem, what we want to do, predict, classify, or identify new patterns. And then we select the algorithm that makes the most sense to solve that problem. And then those are just types of algorithms like linearized regression, decision trees, SVMs, and neural networks, and so on, and what have you. And then we develop the model and optimize it with parameter and sometimes hyperparameter tuning. And then that's kind of like the training data set. And then we test it and see how the model performs on a different blinded data set. And sometimes this can be an external data set. For example, we recently did a study where we used Cleveland Clinic's data to make a model and then validated it in Stanford's data set. So I think that's kind of like the brief up. And then this is kind of like a good segue to talk about our study that Dr. Ferris was mentioning. Our study was looking at how we could use machine learning models to predict major adverse cardiac events after liver transplant procedures. And I think that's kind of the focus of the meeting of the group that Dr. Cywinski and Dr. Ferris lead. And I think that was kind of the idea behind the study. And I think, so just an overview of our study. So like Dr. Ferris said, MACE are the leading cause of adverse outcomes following liver transplantation. And we sought to see if machine learning could help us in solving this problem. So we took all our patients who underwent liver transplant at our center over the last 10, 12 years. And then we split it into an 80-20 ratio of training and test. And we used different machine learning algorithms. And we found that XGBoost model performed the best with an AUC of close to 0.72 and a RLC statistics of 0.60 for time-varying mortality and 0.72 for cardiac mortality over 4.4 years. So this was pretty robust when we considered other risk factors systems that exist. And in fact, the ones that do exist are not specific for like transplants, liver transplant procedures. They're usually for just cardiac surgery. Besides this, only one other notable scoring system that was developed at Northwestern exists. So I think this was a pretty niche field where there was a lot of paucity of data. And I think that's why our paper was well received. And unsurprisingly, what the model picked up in terms of the Shapley value examination was that factors that were most predictive of adverse outcomes after liver transplant included age at diabetes, age at transplant, diabetes, serum creatinine surrogate for renal function, NASH cirrhosis, and echocardiographic parameters like RV, SP, and LVEF. And come to think of it, those are kind of like the things that we think of when we see a liver failure patient. We look at, is his RV okay? Will he able to tolerate like a big afterload or anesthesia? And is he obese? Is he diabetic? Does he have good renal function? And even though the model does not know how a clinician thinks, that's what it picked up, kind of like reinforcing our thought process. And then this is just, again, the visual representation of our SAP summary. And then this is an interesting figure from our paper. So we divided all our patients into quartiles of risk for adverse cardiac events based on our model. And in each quartile, there was the first quartile has patients with the lowest risk, and in the fourth quartile, we had patients with the highest risk. And then we kind of visually assessed that why, if somebody was in the first quartile, why was he in such a low risk? So if we look at this small figure here, it shows that the guy in the first quartile had good EF, he had a good renal function, and he did not have tricuspid regurgitation, kind of like a surrogate for right ventricular failure. He did not have diabetes, and his renal function was good, so he was in the first quartile. But if somebody was in the fourth quartile, he had diabetes, his age was old, he was an old person, he had NASH cirrhosis, and he had high right ventricular pressure. So I think that's kind of like a visual estimate of what to expect if you use our algorithm to risk predict someone. The model will actually also tell you, like, these are the top predictor factors for this patient compared to someone else. So I think that kind of makes sense to a reader who does not have a background for artificial intelligence. And then the other notable examples where AI is being used in cardiology, and like we know, like heart failure readmissions is like the bane of existence for a lot of cardiologists, and they're one of the biggest causes of Medicare and Medicaid dinging hospitals for quick readmissions. So I think when machine learning was like kind of booming in cardiology, this group from Northwestern sought to see if machine learning could help decrease heart failure readmissions. But this study was really interesting. But just to give you a brief up, the study found out that machine learning wasn't as good as, like, did not like perform superiorly compared to traditional statistics to improve prediction. But what the study really pointed out was that the model was as good as the data that you provided it. And so what we learned from that study was that if you want to answer a question, you need to give the model data that it needs to answer that question. So as you know, in your clinics, you see if somebody's coming in with heart failure, most of them are because, or they just forgot to took their Lasix, they didn't have money to pay for the medicine, or they just didn't have resources to come to the clinic on time. So those are like a lot of socio-demographic variables that the EHR just did not have. So it could not make a robust prediction. So the lesson here is that if you want to answer a good question, give the model good data and a clinically meaningful question, and you'll have a good answer. And I think that was kind of really nice about the study. And the other important lesson from this study was to not dichotomize an important outcome, which is more clinically relevant. So suppose, I think having a risk prediction, whether what's the risk of readmission would have been a better question here than like, is he getting readmitted as in a 1 or 0, not as a binary outcome, but as a continuous outcome. So I think that's something that was interesting to learn here. And then, like Dr. Guha said, I think smart wearable devices are really becoming popular to detect arrhythmias. And this was one of the really famous studies that made the Apple Watch really famous a few years back. And this looked at people were given basically Apple Watches to wear. And whenever Apple Watch detects an abnormal rhythm, it sends an alert to the reader. And so in this study, people were given Apple Watches, and they were told that if the Apple Watch gives you an alert, just call your cardiologist, do a telehealth visit, and then wear a Holter monitor for 7 days. And then they saw how much the Apple Watch correlated, like the visual assessment of the Apple Watch in assessing the rhythm based on the wrist reading, and to see if it could detect atrial fibrillation. And the results are pretty interesting, but to cut it short, basically, atrial fibrillation was identified in 34% of the participants, and Apple Watch's reading corroborated up to 84% with that of the Holter monitor. And I think Apple Watch uses an image-based recording strip, which is an AI trained algorithm that Apple developed to detect atrial fibrillation, and it had a really good success rate in this Apple Watch. And don't quote me on this, but I think after this study, the FDA even considered Apple Watch for this purpose. I'm not sure if they approved that. And then I think another really interesting thing is how to see if somebody is going to respond to a therapy or not based on the risk factors, because many times we do things we offer therapies to patients just based on guidelines, but we know that all therapies don't work in all patients. And this is especially true regarding like VFib ablations, CRT device placements, ICD placements for primary prevention. And like in this study, authors use data from the companion trial to see if CRT reduces morbidity and mortality in heart failure patients with intraventricular conduction delay. And basically they trained a machine learning algorithm to see if it could adequately predict who would respond to CRT and who would not respond to CRT retrospectively. And I think their model with an AUC of 0.74 was adequately able to predict which patients would respond to CRT or not. And of note, I'm not an EP guy, but it appears that that was higher than the prediction that can be achieved with current discrimination using just looking at the bundle branch morphology and QRS duration, which is the current standard of care. So I think obviously you won't use this to base your decision, but you can use this data to kind of talk to the patient and the family that this is what you can expect based on what we know. And I think that's really powerful for the patients. And I think that's how we would also use our liver transplant algorithm to tell patients, like, look, you can get a transplant, but you are someone who has a high risk of adverse cardiac events. And then I think the last application that I wanted to touch upon was how AI is also helping us identify the diseases in ways that we did not know. So kind of like a branch point from that visceral fat study we spoke about. This recent work from Mount Sinai looked at all patients with type 2 diabetes and looked at the gene mapping and saw that if all type 2 diabetes are the same or are they different. And to cut it short, they found out that patients, there are 3 different phenotypes of diabetes. And type 1, the first phenotype is more commonly seen. The patients have more likely to have high blood sugar, kidney disease, and eye disease. But in other subtypes of diseases that they picked up, I think cancer and neurological diseases are more common. And this has become increasingly recognized as subphenotypes of type 2 diabetes. And it all stems back from the study. And that actually can help you indirectly treat your patients better. And this is kind of like a representation of personalized medicine. Like if you have a diabetic patient, then you would see which category does he fit into, and then you would appropriately risk stratify that patient. And so that leads to my next question. Like, if this is so awesome, why are we not doing it like all the time? And why is Epic not doing it automatically for us? Like, there are engineers, Cleveland Clinic has money. So why are we not doing it all the time? So some of the common limitations to this is like it needs good data and good models to make good predictions. But data sharing is really, really limited across Epic. And EHRs, unfortunately, are one of the most outdated and like just really, really bad piece of software. So it makes it really hard to share data, you know, like between hospitals and sometimes within the hospital. And then there's a lot of limitations in terms of the variables that we can pick out, like surrogates for geography, socioeconomic status, zip code, healthcare access, vehicular access, can you go to a clinic? All these things are not there in electronic health records. So at least most of the times, and those are really important data to predict disease outcomes. And they're really, really non-uniform. And then each user customizes Epic in his own way. And this kind of makes it really hard to automatically pull data from everybody's Epic across all hospitals to train a good machine learning algorithm. And I think that has been the biggest limitations after what I spoke with people who actually do this for a living. That and whenever they're asked to fix this issue, I think Epic actually has, right now Epic's focused on making it even more personalized for each physician. So we're kind of going in the opposite direction. Like you want Epic to be easy for us as a person and not like all physicians across the border. And then the algorithms themselves are imperfect because they're developed by humans. And so we're constantly improving them all the time. So I think a really good answer to the solution, and something else that I would like to talk about is blockchain technology. And I'm really excited to talk about this because I certainly think that this is going to be the future of healthcare. And blockchain might be will be instrumental in helping AI really, really flourish. for those of us who have limited knowledge of blockchain, it's basically a decentralized person-to-person ledger sharing based algorithm that can help remove all the roadblocks that we see as physicians. So if you could imagine a patient's information like a diary, and you put in a person's information on a piece of diary and you write a number next to it that this is how I'll remember that this is this patient. Another person would automatically be able to retrieve that information anywhere in the world if he can somehow find that record in that diary. So blockchain is a really, really simplified version of this, but it just streamlines information sharing between healthcare systems and organizations, physicians, and patients. And it initially came out when the Bitcoin became famous, because Bitcoin was the first application of blockchain where financial transactions could take place based on really, really encrypted and decentralized ledgers, kind of like the one we talked about. And then people started thinking, why does it have to be just limited to money? Why can't we exchange information using just protected, streamless, and decentralized servers? Like nobody has a single unanimous authority to say, okay, this information is not going to go here, and you can't see this, or and it doesn't, and consequently there is very less risk of HIPAA violation, because if there's no one person controlling it, then he can't leak that information. So it's completely automated and decentralized. And in that sense, more and more people are realizing that healthcare innovation can really, really benefit from blockchain technology. And this is actually pulled from the NIH website to like a brief overview of how blockchain can really help us. And so suppose, and the center is our patient, and we as a doctor write something in Epic, which goes into the patient's record, and then his Holter monitor picks up something which goes into his Holter record, and his vital signs, his MRI findings, his med list, and his lab results, everything goes into his record really nicely, and it gets a key next to it, which the patient can see. And then it gets a double-blinded key that the ledger can see, which can then be retrieved by anyone on the other side. So basically, it protects the patient's identity because nobody knows the patient's version of the key. But at the same time, it allows everybody else to access the information in a de-identified manner anywhere in the healthcare system in a really, really organized way if he has the double-blinded version of the key. And every person's data will be stored on a localized ledger called the local blockchain or the health blockchain. Suppose Cleveland Clinic will have its own healthcare blockchain, and UH will have its own blockchain, Metro will have its own blockchain, and all of this will be in a data lake. Like all the blockchains will be in Ohio's data lake, and I think it'll make data sharing so much easier. And what algorithms can easily extract de-identified data from there to answer meaningful questions. And I think that's the way forward. And it's really interesting that, so I don't know if you guys have heard about Ethereum. It's one of the cryptocurrencies that people are talking a lot about these days. It's a blockchain-based currency that was developed by an emergency medicine resident. And that's currently being developed to share healthcare information across healthcare systems like this. And people are looking into, doing pilot projects where healthcare data will be exchanged using Ethereum in a de-identified manner. And I think California is already starting doing that. I think that's a really promising future. But that's all I have for all of you. And if you have any questions, I'm happy to answer. And Dr. Ferris, I don't know if you have a few words.
Not really, very well done. And, I think another area that we may be interested in as practitioners, VJ, with hopefully people like you helping us with is genetics in helping us navigate through genetics in cardiology and in medicine in general. I think that's a field that is fraught with unclarity, and I think there is potential deep machine learning to help us with navigating through the results that we get and the interpretation and the possibility that the patient will have a certain not just genotype, but phenotype.
Thank you, Vardhmaan. Great presentation. I'm going to move on to the next speaker. So I want to introduce Dr. Sadeer Al-Kindi. He's my colleague from UH. He's a practicing cardiologist and a physician scientist at University Hospitals, Case Western Reserve University, with expertise in multi-modality cardiovascular imaging and cardiovascular outcomes. Dr. Al-Kindi currently directs the cardiovascular phenotyping laboratory at university hospitals, where his efforts are focused on precision population-based cardiovascular imaging and predictive modeling. He also leads research efforts related to the Clarify study, which is the largest no-charge calcium score cohort in the United States. Welcome, Dr. Kindi. We'll take all the questions at the end because of time. Thank you.
Thank you for the invitation, and thank you everyone for attending. I'll just share my slides, 1 second. Can you see my slides? Hello? Okay, excellent. Well, thank you for the invitation. So the title of my talk is Applications of Machine Learning in Cardiovascular Imaging. And I have no disclosures, but as a cardiovascular imager, I see an amazing applications of AI in these multimodality imaging, because we have so much information and we actually drown in data. So you can see the variety of different imaging techniques that we are able to capture, and within each imaging technique there is multiple types of images that give us different information about the myocardium, about blood vessels, coronary arteries and aorta and lung and so on and so forth. So this slide gives you a gist about kind of what is the what kind of imaging modalities we were talking about, and it kind of extends from an X-ray, simple X-ray, echocardiograms, CAT scans, MRI, intravascular imaging, which includes OCT and IVUS. We also have CT and electrophysiology mapping and MRI and SPECT and other nuclear imaging. So applications of artificial intelligence in general, or machine learning more specifically, can be applied to electronic health records in general, which can actually draw data from lifestyle changes, lifestyle behaviors, genetics, microbiome, and other kind of biodiversity data. You also have social media, omic data, and wearable that are increasingly being utilized and integrated into several health record systems. And that can be fed into a precision medicine platform, which can actually be fed into a pipeline for machine learning and artificial intelligence. And that could include supervised learning, unsupervised learning, and additionally, although minimally used, is reinforcement learning in precision medicine, especially cardiovascular medicine. So I think, in terms when I conceptually think about applications of machine learning in cardiovascular imaging, I think of 4 different applications. So one could be, as I alluded to, there's multiple imaging modalities in cardiovascular medicine, and oftentimes they provide similar type of data, but how can we choose the right person for the right procedure or the right imaging study? So oftentimes we struggle between the choice of different stress testing techniques and things like that. And I think there is a good application of machine learning in the choice of the ideal imaging modality. Also, obviously, we have a lot of segmentation and tracing and things like that, and measurements that we can do, and we do on daily basis on cardiovascular imaging techniques, and machine learning techniques can actually help with this automated segmentation and reporting. We have a lot of data that we acquire from these imaging studies, and whether it's measured or reported clinically or not measured, and that can actually help us to identify novel phenotypes. So for phenotypic discovery, it would be important. And integrated prediction is obviously would be very important by integrating clinical data and imaging data to improve prognosis estimation. So this is one of the pipelines. So basically you have, imaging data, which can, as I mentioned, there's edges, shapes, features that we can acquire, also color, brightness, and other kind of what we call them radiomic features that can be acquired from images. We have electronic health records, which include prescribing, lab data, and we also have some patient-generated data, which include diet, activity, and lifestyle. And if in some situations we have additional genomic and transcriptomic data. These can be fed into a computational technique, as we talked about, and would also help us with imaging applications, so quantification of imaging features, notification tools like red flag images, workflow prioritization, which has already been utilized in various health centers, and will also help us for decision support and diagnosis and prognosis. So how do we do this? We get raw data from various sources. Let's take an example of CT. We pre-process the CT and maybe extract the coronaries, extract the myocardium. We do some transformation, normalization, and we identify different clusters. So there are various clustering algorithms that can actually identify patterns within these data sets and can identify novel kind of phenotypes that we can then take and test with respect to prognosis or response to therapies and whatnot. This is another kind of way of applying machine learning techniques in automated segmentation and reporting. So we get data from scheduling and acquisition of patients. We obviously do image reconstruction and produce the image. And then we can, machine learning can actually facilitate the segmentation of the left ventricle, right ventricle, left ventricular wall, and it can also obtain additional novel features with respect to myocardial density and texture and so on and so forth. We report these. These can be actually automatically reported into structured radiology reports, and would also be able to be integrated to identify novel prognostic clusters. This is one of the examples as to how can we identify features of plaque on coronary CT to identify a hemodynamically significant lesion. So this is as measured by a fractional flow reserve, which is basically a measure of hemodynamic significance. And you can see that this study specifically, they acquired a lot of different features from the plaque, the stenosis, and the myocardial density, and so on and so forth, that's supplied by this blood vessel. And they were able to identify the probability of FR less than 0.8, which is hemodynamically significant. So as you can see, the features that turned out to be important are not necessarily the same features that we typically think of, but we have contrast density difference, which turned out to be important. Obviously, age and gender. We have a lot of different kind of features that can also be associated with FFR less than 0.8. And in this particular study, they were able to achieve a very good discrimination of positive versus negative FFR with a 60%, modest, but still it's important to actually improve statistically significant discrimination of hemodynamically significant plaque. So I'm going to talk about the 4 examples of machine learning applications to fit in the model that I talked to you about, which is the 4 kind of different applications in cardiovascular imaging. So example 1 is a choice of a functional versus anatomic study for evaluation of coronary disease in patients who have chest pain. So this group from Yale, what they did is they took a trial, which is called the PROMISE trial, which is an NIH-funded study that looked in randomized patients who come with chest pain with a clinical suspicion for CAD, and randomized them to anatomic imaging, which is coronary CTA, and functional imaging, which is done using SPECT nuclear scan. And the trial was eventually negative. There was really no difference in major adverse cardiovascular events over 1 year in comparing the 2 imaging studies. But this group sought to identify subgroups that would benefit from one or the other. So what they did is they identified various variables that are obtained through phenotypic variables that are obtained through the trial. And this includes demographics, risk factors, presenting symptoms, EKG variables, medications, and clinical assessment. And by using all these variables, they were able to map these variables throughout a technique called a UMAP technique, which is basically shows you the different groups, reduces the dimensionality in from 200 variables to a 2D kind of clusters. And from these clusters, you're able to identify neighbors for each patient. So for example, if you take a patient here and you identify about 5% of the neighbors that are around this patient and see what their outcomes are within a SPECT study versus a CTA study, functional study versus a SPECT anatomic study, and see how they did. And then you repeat this repeatedly into different areas, and you can identify which patient group can benefit. So this map shows you how some groups, well, although they're adjacent to each other, some groups favor anatomic testing and some patients favor functional testing. And the definition of that is basically if you take about 5% of the population here and you look into how many of them went for CTA, how many of them went for SPECT, and what are the hazard ratios of major adverse cardiovascular events in each patient. So this is an example where there's a 59-year-old woman who has diabetes, hypertension, never smoker, and no dyslipidemia, presenting with atypical chest pain. Right, so you have a Diamond Forrester score of about 20%, which identifies pretest probability. But it turns out that this specific person can be present in 3 groups, A, B, C, D, basically B, C, D here. And although they have very similar phenotype, they are different a little bit with respect to the other risk factors. So for example, this patient is on a calcium channel blocker versus this patient is on beta blocker, this patient is on a whole bunch of other medications. And it turns out, although these patients seemingly look the same when you look at them, this patient population specifically did better with functional study, as you can see, as a freedom from major cardiovascular event, compared with an anatomic study. While this specific patient in number C, they didn't do any better with either study, and patient in number D did better with an anatomic study. So using this technique, you're able to actually identify what is the ideal situation, the ideal testing modality. And using internal validation, they were able to show that if the software or the machine learning algorithm, there was a concordance between what test was performed with what the machine learning algorithm recommended, you get better outcomes. And this is seen in the 2 colors as purple and red, and they're superimposed on each other, compared with if there is discrepancy between what the algorithm recommended compared with what the test was performed, and they do much worse. This was also applicable in an external study from another trial called Scott Hart, and that also performed very well. So the authors were able to actually come up with a very nice kind of API, so to speak, to look into, on a free website, you can actually plug in the variables of interest that turned out to be important for this algorithm, and it will tell you relative hazard for anatomic versus functional, and it will give you a recommendation for what is the optimal imaging modality in this patient population. Example number 2 is how can machine learning help us with the segmentation, reporting, and so on and so forth. And this is a group from Stanford where they took echocardiograms. They took the 4-chamber view from echocardiogram and they segmented it using, looked at the manual segmentations that are done by the technicians typically, and they fed it through a convolutional neural net. And they were able to identify the segmentation area, throughout systole and diastole throughout all the cardiac phases. And as you can see, that the ejection fraction that's estimated by the method, by the machine learning model, was very well correlated with a manual ejection fraction measurement. And more importantly, this machine learning model was able to predict the presence or absence of heart failure with an AUC of about 0.97, which is excellent. And this actually performed very well in, they were able also to measure GLS, global longitudinal strain, ejection fraction, and other things that could be measured from echocardiogram. And that performed well in internal, external testing. And you can see it here as an example of how this left ventricle is segmented throughout the cardiac cycle and how the volume, actually an area, because it's a 4-chamber view, can vary throughout the cardiac cycle. And this really worked very well in patients who have sinus rhythm and atrial fibrillation, as long as you have at least 3 beats of sampling that you get in these patients. And example number 3 is really phenotypic discoveries I talked about. So we know that machine learning can actually help us using unsupervised learning approaches, help us identify novel approaches, novel clusters, and novel phenotypes that can vary with respect to outcomes. So a perfect application of this is actually heart failure with preserved ejection fraction. And this is kind of we call all patients who have heart failure, but they don't have what we call systolic dysfunction or reduction in LV systolic function. We call them heart failure with preserved ejection fraction. But we came to realize that these actually are very heterogeneous patient groups that are all under same umbrella. And so far, all the trials that have been performed in HFpEF patients, they really were negative, suggesting that maybe we're not selecting the right patient population. Maybe this is, we're not targeting the right patient population for these interventions. So this group from Northwestern, they took their cohort of about 300 patients who have HFpEF by clinical diagnoses, and they took basically all EHR data that are relevant to them. So, all lab values, EKG data, echo data, and they fed it into this clustering technique, which is a method of unsupervised machine learning. And you can see that the patients clustered into three different groups that are related to each other, related within, patients who are related to each other within the cluster, but they're different from the other cluster. And if you focus on this heat map, shows you that there is different signatures or fingerprints for each cluster. Now, it turns out that the cluster one was a younger, patient population. They had very moderate or mild diastolic dysfunction and have relatively normal BNP. Cluster 2 was obese diabetic patient with high prevalence of obstructive sleep apnea and severe LV relaxation. And group 3 was older patients who have atrial fibrillation and CKD and myocardial remodeling. Now, this unsupervised learning technique is really agnostic to the outcome. We don't, the software doesn't really know what the outcome is of these patients. So surprisingly, or maybe not surprisingly, when you look at the clinical outcomes of these patients, which is freedom of cardiovascular hospitalization or death, these phenogroups, so to speak, or clusters did very differently. With the best one, the younger, phenogroup number 1, which is the younger patients who have mild diastolic dysfunction, did the best, while the older patients with CKD and atrial fibrillation did worse. And they also have differential distribution of cardiovascular events. So this can also be applied to different cohorts. So this is a study from TopCat, which is another trial of trial cohort of patients who have HFpEF, and you can see that the phenogroups were actually applicable to this cohort that can predict differential outcomes with respect to primary cardiovascular events, mortality, or heart failure hospitalization. So in conclusion, really, machine learning has a role in the choice of imaging studies, automated segmentation, phenotypic discovery, and also integrated prediction, which can actually be across these three examples that I provided. I think machine learning is likely to provide a process to improve the speed and quality of acquisition, also reduce measurement time when we talk about image segmentation, and also allow prompt diagnoses, which can alert physicians to take an action for patients. And then there's also a need to develop applications, AI applications that can bring big imaging registries that can facilitate deep learning approaches and increase the utility of imaging testing for the patient. So thank you very much.
Thank you, Sadeer, and we'll open it up for questions. And I'll start with one question for Vijay of the many questions which came through. What was the main challenge you had when you did your study?
The biggest thing was cleaning up the data set. I think when you have such a big data set, I think ensuring that everything is clean, because like liver transplant team has its own data set, the imaging people have their own data set, and biochemical parameters are different, and then which biochemical parameter did they choose? So just cleaning up the data set was, I think, the most time consuming part. Once you have a good starting clean data set with well-defined outcomes, I think then it becomes easy to train the model. So I think that's why I keep stressing that if we have really good starting data, I think then we can have really good answers.
And another question which sort of came through, I guess, for everybody to think about or answer is, I think, what should be like maybe the one thing which every healthcare system should spend on? Like, should they spend on having an informatician to make sure all the data coming in from all sources are uniform or like rather harmonized
Yeah.
pre-analysis, just baseline, or is there something else? I mean, Dr. Ferris, Dr. Cywinski, Piyush, Sadeer, anybody can answer this question.
I would just like to put it, my answer. I think I'm a strong advocate that we really need to homogenize data, not within a health system, but across health systems. And I think that's the best way forward. If there is a way to invest in that, I think we should do that.
I think the answer is at a national level and not so much for the healthcare systems themselves. It has to be prioritized across healthcare systems. So it has to come probably from Washington in terms of what healthcare system, how do healthcare systems and EHR talk to each other? And once the payers start to force us to clean up our data sets, then we will probably. But I don't know that this will be done voluntarily by healthcare system. And to say anything, I am optimistic actually. We're far better today than we were. But the data that we're dealing with is data that is manually put in. And Vijay and I looked at the manuscript, several times, and we looked at the different models and what they predicted. And one thing that Vijay kept referring to the patient as a male, but if you look at the gender in our data, it was actually the gender did not play a role in in predicting mortality. But there's a lot of biases that we might have as clinicians. We expect diabetes to be on the top, but it may not be on the top. Age to be, so there's certain models did not show age at the top. That made us lose confidence in what we were doing at some point, and we had to go back and look at the data and look at the models. And Vijay can talk more about this. But to answer your question, I think it has to be imposed on us, and this has not been an easy process. It's a little challenging because cleaning the data is not easy.
Yeah.
Thank you. And then one question for Dr. Al-Kindi. I mean, what do you think is the next or like the one use of AI which will come into practice? I mean, there's so much research as we see, but like in the field of radiology, a couple of algorithms have been FDA approved to be used, and they are actually used Vijay had mentioned as tools to help the radiologist rather than replace the radiologist. What do you think will be the case in cardiology?
Yeah, I think there are multiple applications, and we're already seeing some of this. I think there's a lot of enthusiasm, at least when it comes to coronary disease. There's a lot of enthusiasm about identifying the plaque characteristics that may be more prone to rupture. Basically, using plaque characterization of atherosclerosis to identify better prognosis. And I think this will come in very soon, if not already in. I know company at least is working on it, and they have something that will be coming in the pipeline called HeartFlow. And HeartFlow is actually is a company that has received FDA approval/clearance to identify FFR using CT, not necessarily based on machine learning, but they are working on a solution to work on plaque characterization using AI by fitting data towards, they have more than like 100,000 scans that they accumulated over the past few years that they're fitting models and identifying outcomes. And I think it's nice to apply it to imaging because the data is relatively cleaner compared with kind of EHR data, which could be subject to a lot of bias that, billing and DRGs and whatnot, and there's billing codes and non-billing codes and so forth, and the variability across institutions in terms of even lab acquisition and things like that. So I feel like, objective data, including, for example, EKG, including potentially even echocardiograms, but more so with respect to advanced imaging, a little bit more homogeneous and a little bit more objective.
Thank you, both speakers. I mean, I'd open it up to Dr. Cywinski for any final comments before we end for the day.
No, I think it was excellent session, and I learned a lot from those talks. I just got a question. I'm just going to throw it out. So, do you think that in the future, really way to go is number one to make this open source data sets available for everybody, in a way they are de-identified, and actually they are not living in a silos of single institution, but they are essentially pulled into these data lakes where everybody can tap into and test the models? That's the first question. And number two, how do you foresee the future in terms of standardizing those data elements which we right now input manually? And that's what Dr. Al-Kindi said, that comparing to the imaging data are far more heterogeneous and hence difficult really to analyze and make sort of wide-reaching conclusions. Do you foresee that in the future, we will be forced actually to operate, speaking the same language across the whole healthcare system, so to speak?
Yeah, I think what maybe I can answer part of this question. I think what we're realizing more and more in the literature that's building up in AI and machine learning is that a lot of the data that is actually input manually, the dirty data, so to speak, like the EHR data, can also be reflected in the more objective data. So there's a lot of literature now. You can actually even predict age based on EKG features. You can predict sex. You can predict the presence of diabetes. You can predict variety of different kind of diagnoses based on more objective data. So that, I think that may be one way of overcoming the challenges with EHR kind of billing codes and so on and so forth and diagnoses, because of two reasons. One is there are a lot of patients who are not diagnosed with whatever we want to input into the model. For example, diabetes, we have a lot of patients who run around, they don't know that they have diabetes, and they may not have a code of diabetes. So, how can you fit a model like this, data like this into a machine learning model becomes very difficult. But perhaps depending on variety of different patient-generated data that can actually predict the presence of these diagnoses would be one way to overcome this. Number two, I think for sharing data, I think there are a lot of efforts these days into actual integration. A lot of I know at least one company that started off of the Cleveland Clinic and kind of got bought by IBM Watson Explorers has done this to a certain extent, where they basically deposited a lot of kind of cloud-based approaches to identify diagnoses using natural language processing and codes and kind of multi-source data. And now they're housed all in a de-identified fashion within IBM Watson. And I know Epic is doing the same thing to a certain extent. So I think there's a lot of applications there.
Thank you. So I think we are running out of time a little bit, but I think this is the testament to the quality of this session. So I would like to take this opportunity to thank everybody who participated, in particular speakers and the moderator. It was really great session. I hope in the future we can repeat it. And with that, if there is no more questions, I would like to close the session and thank you everybody for participation.